Good afternoon, and welcome to an open discussion on well-being strategies for hospitalists during COVID-19. My name is Luke Heisinger, and I am the Practice Management Coordinator at the Society of Hospital Medicine. Before we begin, I have a few quick announcements and instructions for today's webinar. We do have a couple of upcoming webinars tomorrow that are listed here on this slide. If you are interested, please visit SFHM's dedicated COVID-19 page, where you can register for these webinars and access additional resources on coronavirus that are updated regularly. We are hoping to use our discussion today to assemble a short list of strategies hospitalists can use to promote well-being. Our intention is that this resource will live on our COVID-19 page and serve as a reference guide of different ideas, practices are currently using. We do plan to update the list as new approaches are developed, so if you do not get a chance to share with us today, we invite you to join our conversation on HMX, the link for which is listed right here, or reach out to SHM directly at ideas@hospitalmedicine.org. For those of you who are planning on sharing today, you will need to log into the webinar on your computer and also call in with your phone to speak. To do this, select phone call under the audio tab on your control panel and follow the instructions listed here on this slide to link your phone and your computer, which you will need to do in order to use the raise your hand feature to be unmuted. If you are having any technical difficulties, please message us on the chat. Our format today is slightly different from previous webinars. The first 20 minutes or so of the webinar will be used for our four panelists to share what initiatives their practices have been doing, and will be open to their discussion and input. Afterwards, we will be opening the floor for any questions or for you to speak about what strategies your team has been using. As usual, we will be fielding questions in the questions box, so feel free to use that feature at any time. Lastly, here are some simple guidelines for sharing today, along with some questions we would love for you to respond to. We do have a decent amount of people on the webinar, so please be mindful of your speaking time as we want to try and give everyone who wants a chance to share. All participants will be muted for our panelist discussion, after which you may use the raise your hand feature to request to be unmuted. The order will be first come, first serve, and we will announce when it is your time to speak. Please make sure that you remember to unmute your phone on your end so we can hear you as well. So with all that covered, joining us today are Dr. Sarah Richards, Dr. Kevin Conrad, Dr. Rehan Qayyum, and Dr. Rachel Cyrus of the Practice Management Committee's Wellbeing Subcommittee, who will be sharing what their practice has been doing to promote and maintain well-being during the COVID-19 pandemic. Each of them will introduce themselves. So at this time, I will now turn the presentation over to Dr. Richards. Thank you.
Well, good afternoon, everyone. I am joining you all from Omaha, Nebraska, and it's a pleasure to be here today. I am a hospitalist. I spend most of my time with medical students, well, not right now, but with our resident trainees. And then I have an administrative role for our system, looking after patient experience and provider experience. So just wanted to share a few things about our organization and specifically what we're doing in hospital medicine to promote well-being amongst our physicians and our APP colleagues. So I would say that we are lucky here in Nebraska. I was telling our panelists earlier that we only have about 15 or so COVID positive patients right now in our hospital, about 30 or so in our rule out units, and our peak is supposed to be around May 1st or so. Social distancing has accomplished a lot, and we're not a very populous state and pretty spread out, so we're lucky in that regard. That being said, we're not immune to some of the stressors that are impacting us all, just in terms of our day-to-day life and how things have changed in terms of those of us with children, doing homeschooling, having a change in workflow, different responsibilities. And so we've tried to be as proactive as we can with our colleagues. So I was just going to highlight quickly 4 things in the next couple of minutes that we're doing that I think have been helpful and can provide further detail if needed. So one would be group sessions that we've held on stress management and resilience. And we really set the intent out in the beginning that this is really about letting you know that you're cared about, letting you know that you're not alone, letting you know that if you are stressed by one of many different stressors, that's normal. So trying to normalize the things that we're all stressed about. So whether it be like our concern about whether or not we can don and doff our PPE correctly, or another common stressor is could I be an asymptomatic carrier because I'm caring for COVID patients? Like, could I take that home to my family? And so we start to talk and normalize some of those fears. We also talk, I bring a psychologist or a psychiatrist into the Zoom webinar, into these workshops, and we talk about how to identify our own stress, what are cues for stress, so that when we know from a physical symptom or an emotional symptom or a change in our behavior, that maybe we're not quite right. Then we provide some evidence-based tools, whether that be relaxation. We actually do deep belly breathing and progressive muscle relaxation like during the workshop through Zoom, which is everyone's favorite part because it's like mandatory relaxation time during a work webinar. And then we also talk about distorted thinking, do a little bit of cognitive behavioral therapy, talk about being more positive, looking for the silver lining and things of that nature, and then make sure that everyone knows what resources are available for support. The second thing that I think has been helpful is offering one-on-one peer support. So we have kind of a confidential network where if somebody reaches out, we'll set them up with a peer who has volunteered to just be a listening ear. A lot of our colleagues in psychology and psychiatry have kind of volunteered to provide the service, and that's been really well received. Another thing is, I'm sure many of you in your divisions of hospital medicine or at your hospitals have some sort of an appreciation program. We just took ours and we like put it on steroids. So we just communicated it like crazy. We added so it's all virtual. There's an option to pay it forward so that when you receive appreciation, you're prompted and encouraged to now also appreciate somebody else, and all you have to do is click a link. So we're trying to make it really easy, and then we're CCing everybody's supervisor and sometimes their supervisor. So if I recognize one of my hospitalist colleagues, our section chief, our division chief, and our department chair will see that. And so we're trying to promote a lot of positivity. And then finally, I think many of us are doing this, but trying to communicate as often and as much as possible. So we typically meet for 90 minutes once a month as a section. Now we're meeting every week for an hour or more. And then every single day, our leadership team checks in for about 30 minutes or so. And sometimes we just talk and share what's going on. And sometimes we have something to update. Somebody has a question. We want to bounce ideas off of one another. We're just seeing, in a way, we're seeing each other more frequently because we have these Zoom meetings where we all turn on our video and get to see each other's faces. So I would say those are 4 things that we've been doing here in Nebraska.
Great. Thank you, Dr. Richards. At this time, we'll turn it over to Dr. Qayyum.
Thank you very much, Luke. And I also want to thank the Society of Hospital Medicine, our Practice Management Committee and Wellbeing Burnout Subcommittee for arranging this webinar. I'm Rehan. I'm chair of the Division of Hospital Medicine at VCU School of Medicine. I'm also a member of the task force for professional well-being within our institution, as well as a co-chair of the well-being committee within the Department of Medicine. As Sarah has pointed out, this is definitely a pandemic in which well-being can be challenging. Of course, we can continue usual well-being initiatives, but what to do in this pandemic is unclear, and in these unprecedented times, there is no playbook that we can follow in these situations. So at VCU Health System, what we did both in hospital medicine as well as for our wider institution was to really listen carefully to our hospitalists as well as our other providers and see what their needs are. Through this listening process, we identified really COVID-19 specific, some unique stressors, and then we sort of thought of how we can address and which ones of those we can address. So some were personal issues because of lockdown across the states, and Virginia is one of the states where our governor lockdown state in March. Some are work-related issues because of COVID-19 related, some changes in workflow, and then obviously psychological stresses that were there. And so we tried to address some of these issues. Like I was saying earlier, that because of lockdown, schools were closed, and similarly, most childcare facilities also were closed. And as most of us know, hospitalists are typically a younger group of providers, and we have children, small children, and so these school closure and childcare facilities really were difficult, particularly for those families where both parents were physicians. So very early on, we did a survey of our faculty and of hospitals and other providers to see who needs childcare help so that we can arrange that help. We identified close to 200 across the health system who asked for help for their children, and we were able to make arrangements through our health system to provide childcare for those physicians and other providers who needed help with childcare. There were also, there are also concerns from hospitalists about, that they may take this COVID-19 and transmit it to someone in their family. And so that concern was brought up really very early on, before even we had first patient. And so we started making arrangements for those physicians or other providers who were concerned about transmitting COVID-19 to their other family members, elderly or immunocompromised. And we made accommodations close to our hospital in a hotel for those who wanted to stay there. They could call our central command center, and we would make arrangements for them to actually stay there. One other thing that on a personal front came up was those whose children are a little bit older. They obviously had questions about COVID-19, particularly about the well-being of their parents. I can give an example of my daughter who asked me one day that what will happen if you and mama both get COVID-19? My wife is also a hospitalist. And so to address those, we had one session which we called, which we labeled as COVID's Kids Connection. And in that we had children ask questions. This was facilitated by a child psychology specialist, this Kids Connection session, to help on a personal level our hospitalists or faculty and providers. Then obviously there were work-related issues and lots of work-related issues that came up. One thing that Sarah had pointed out also is we trained and retrained and tested and retested our hospitalists, making sure that they are able to use PPE comfortably. They know how to take it off without touching any other parts, and therefore they feel comfortable in using it. They have practiced enough. We also build a new intranet page, which is being updated very frequently, sometimes almost daily, on which we have all resources, both for management as well as for discharge of these COVID-19 patients, which clinical trials we are currently running on these patients, who are PIs or the contact person for those trials, who are which ones are nursing homes who are able to take these COVID-19 patients when they are able to be discharged from hospital. And we are sort of building an app now, which we are expecting to release either later this week or early next week, for our physicians to be able to use it on handheld devices for all these resources, both for treatment, management, discharge. We also, of course, brought Telehealth to the bedside, so that physicians don't have to go in to patient's room each time they need to talk to patient, or patient has questions. And so they were able to communicate using iPhone in patient's room, iPad outside. So we were able to communicate with patients that way, therefore decreasing exposure. So that helps to decrease anxiety a little bit, both for physicians and nursing staff. We also had COVID-19 specific teams. We have those who are taking care of COVID-19 patients, for those who are being admitted for rule-out purposes. One other thought that came up early on was about surge capacity and how we are going to plan for surge. One of the concerns that many hospitalists had was that we will be the one who will be taking all the brunt of this, and we may or may not get support from institutions. So we developed this institution-wide surge plan where we made sure that everyone is going to be able to support if we get really overwhelmed by the number of patients, and shared that with hospitalists, and they were really happy to hear that the whole institution and all physicians, including the surgeons and others, are going to help us if things really get bad. We also really remain focused on communication and transparency. Our leadership, institutional leadership, 3 times a weekly, 1-hour town hall meetings through Zoom. We do those, and more than half of the time is set aside for questions and answers and raising concerns. And those are depending on if someone wants to share those anonymously, people can raise those concerns anonymously to the leadership team. So those are attended by both our health systems president as well as dean, chief medical officers, chief financial officers, and other institutional leadership to be able to answer questions and concerns raised in a timely fashion. We also, of course, continue to update our team about where our PPE stock is, because that is something that has been a concern across many health systems, and what we are doing to make sure that our PPEs are in sufficient quantity available to our providers when they need it, and how we are procuring or other things that we are doing. There was one other concern that was raised was about the financial viability of the institution, because there's been ongoing news about increasing stress on health systems and health systems having to furlough their workers. And so we recently had last week, our CFO did one of the town halls in which he went over our financials of the institution and what are the contingency plans and those type of things. So really that tells quite a bit about the transparency that our institutional leadership is really trying to help the anxiety and support well-being. One operational decision that we made really early on was to develop a central command center staffed by our infectious disease folks, our epidemiology folks, our administration, our nursing folks, so that there is one central area, and this is staffed 24/7, where one can call in for any questions, so that we have a consistent response across the institution for anything that comes up. There were, like Cyrus pointed out, we also similarly have both group sessions as well as individual sessions for counseling and for support that are available to our hospitalists. We have done quite a few group sessions, and then those providers who need individual support, we have been able to arrange those also for them. It's particularly challenging for some of our providers who have been used to a more closer contact with patients to see their COVID-19 patients. For example, one incident in which a comfort hall was on with COVID-19 patients, and provider could see that patient from outside passing away without being able to be next to the patient, which was a little difficult and needed some counseling support there. One other thing that we have done, I think, which is really I think interesting and very helpful for our hospitalists, is engaging the local community and showing that actually how our local community appreciates what we do. There were lots of thank you cards that the community, and particularly children and others, who wrote. So we pasted those cards in the hallway from parking to the hospital. Several other places in the hospital, we put those on larger boards and hung there to make sure that the providers realize how much community appreciates them. The community also partnered with us to provide free lunches or dinners to faculty and to hospitals and providers when they're working in hospital. And so that's another way of showing appreciation by the community. our VCU university community outside the health system has also been quite helpful in providing us with some creative and innovative approaches to issues that we are, for example, sterilizing N95 masks using UV light and how to perform and how long it's gonna, how often we can do that stuff. So those type of things that university was our university faculty outside the health system was able to help us in our engineering department, mechanical arts, and other schools. And one other thing that I think quite interesting, that one last thing that we were able to do. One of our hospitals actually started a webcast called COVID Bolus. It's a daily 30 minutes webcast in which it goes over, brings in a new guest every day, and goes over different aspects of COVID-19 and talks about, one talk was about clinical trials, management of patients, cardiac manifestations of COVID-19, epidemiological perspective, surge planning, those type of, all these questions and things that come up. And several of those actually guests were hospitalists, which really, I think, which really allowed them to feel that professional recognition and professional well-being. These are some specific initiatives that we were able to do during these times, and continue to do those. And I really want to thank our institution's leadership, who is really very responsive, supportive, and provider friendly to support us through this process.
Thank you so much, Dr. Qayyum. Dr. Cyrus, we will now turn things over to you.
Sure. Hi, my name is Rachel Cyrus. I am the Clinical Practice Director for Northwestern Memorial Hospital in downtown Chicago. Also one of the key medical directors for medicine. And this has definitely turned our lives upside down. Most of our care now is COVID care. We have multiple units filled with COVID patients. We actually turned some of the things we love teaching, for example, over to people that might be able to take a teaching service that wouldn't normally be taking a teaching service at this time. Had some others helping us out on our oncology services, for example. So most of our days these days are working on the COVID units and also doing admissions, which tend to be mostly COVID these days. And so definitely thinking about how do we keep people feeling okay during this time and not overwhelmed. And then I think it'll also be a challenge looking at how do we come out of this? You know, how do things return back to normal? And is there a period that is overlapped coming up in the future? So we've done a number of things. I'm so happy we're having this webinar so I can pick up other ideas from other groups. And I'm looking forward to hearing from the callers on the phone on the webinar as well. So one of the things that was interesting is in talking to our psychiatrists, they were saying that there's 4 different types of stress injury, and that usually you might hit 1 or 2 of those areas, but in this case, you're really hitting all 4 areas. And briefly, just to talk about the areas they mentioned, one is the threat of life, and that's worry about your own life, or a lot of people are going home to young children, elderly parents. Loss, and that might be patient loss, it might be losing parts of yourself, inner conflict or kind of moral injury. And I've had a lot of people talking about, for example, today one of our discussions was telehealth. So we're doing a lot of telehealth visits. It's something completely new for us. And at the same time, there's a little bit of guilt about not going into the patient room sometimes. Is that something that we really should do? That's normally what we would do. And what does it look like if the nurse is going in, but I'm not going in, and the guilt around that. Thankfully, we haven't had to allocate any resources at this time. But in the disaster planning, there's also the what if, we should run out of ventilators and have to make some very difficult decisions. We haven't had to run into that, thankfully, but the talk and the discussion is there anyway. And then the 4th category just being fatigue, and that's general wear and tear. That's emotional and physical fatigue. So I can see how each one of those areas would be affected as we're going through this total change in what we thought we'd be going through right now. So one of the things our group tried to do from the get-go, we noticed, and you probably all saw this in your groups as well, is that people just wanted information, and there wasn't a lot of information to be had on COVID. A lot of the planning was just starting and going on because it took all of us by surprise. Some of us had a little more time to prepare than others. You know, in Seattle and in New York, you really didn't have much time to prepare at all. And so one of the things we tried to do at the beginning was just put out as much information as we could so that people could see, okay, we might have answers for some of these things, but they are indeed being worked on. As this continued, and so I've tried to be very transparent with the information I get from our hospital leadership, from the information from the various hospitalists who are working on different committees in different areas, and putting that out. We've had a daily updates section that I've been putting out as practice director. Our Friday faculty meetings, we normally had guest speakers on Fridays, and they've turned into a question and answer session every Friday where people can send in their questions in advance. We might bring a couple of key topics in or experts in. We had ID, for example, coming to our Friday meetings. We've had infection prevention, we've had palliative and ethics. But then we also make sure we address those questions that people have asked, and then we also go through what is the grand plan at the moment, knowing that this can change all the time. I think that's one of the real challenges here too, is just things are changing during the day even. So just changing so fast. We did develop a website, different from our normal website, where we could just post all this information that we had and organize it, and people could find protocols, because we developed a lot of protocols around COVID care, admissions, discharge, resources. For our wear and tear, we did upstaff quite a bit, trying to decrease the COVID patients have a lot of workload. We wanted to try to make sure that you felt like you had the time to take the care that you need to and face some of the barriers you might need to during the day. So we increased our staffing ratios by using those volunteers to take teaching, to take oncology, for example, using some fellow volunteers to do admitting shifts. We encouraged hospitalists to change their normal ways. A lot of our hospitalists like to do 7 on, 7 off during this pandemic. We said, you know, if you can switch with somebody, someone came up with a great idea of doing a Thursday swap. And so while some people have just kind of done, I'm going to do 3 days, 4 days, 3 days, 4 days with a partner, which some groups do already, we had some people who really kind of liked their 7 on, 7 off and said, you know what, we're going to switch Thursdays. And I thought that was kind of a clever idea, just to break up things a little bit and give a little bit of respite. So we encourage shorter stretches. We as leadership and our unit medical directors have been rounding in the workrooms as well and checking in with people more frequently, just to try to help with that sustainability once the adrenaline runs out. Because I think we've all been on adrenaline for a good 5-6 weeks now. And then around coping, one of the things that we found is patient anxiety is so dominant that we needed to find help for us in treating our patients' anxiety. And so we roped in our psychologists and our ethics and our palliative doctors for that. And the interesting thing, we don't normally have a lot of interaction with psychology, but through psychiatry, they were able to rope in psychology students so that if people had very anxious questions, they could, or very anxious patients, they could offer it as a service. And so that has been kind of neat to be able to get a psychology consult just for someone to sit and talk through things on the phone with the patients. We also increased our staff a lot with nurse practitioners from surgical areas, for example, who could help with answering patient questions, answering family questions. They tend to be pretty much similar questions that can be answered by the CDC website and once we develop the answers. And then we had our palliative care. So the collaboration during this, we, instead of our normal interdisciplinary rounds, we actually incorporated the MICU and palliative care and ethics, as well as anesthesia, because we were finding when people went downhill, they went down pretty fast. And so in order to better identify patients earlier, in order to better identify patients earlier and be able to take care of them with a little bit less stress and phone calls, we incorporated these new players, MICU, anesthesia, ethics, and ID into our daily interdisciplinary rounds on our COVID units. And then lastly, we have a wellness committee, which has stepped into high gear right now. And so they have started weekly reflection debriefing sessions, which I attended one today. Again, just for reflection, a little bit of meditation. They've put out resources just for stress relief, zoos that are doing virtual visits, things to do, just kind of fun things. And then they also have been coordinating appreciation for other areas. And I think giving back, we have a lot of desire for people to give back in other areas. And so I think just even channeling hospital medicine is bringing treats to the nursing units, of X, Y, and Z has been very helpful too, and made just people feel good about themselves. One of the best things that has come out of COVID for us, I would say, is just the collaboration with other services and other disciplines.
Excellent. Thank you, Dr. Cyrus. And our last panelist, Dr. Conrad, will now open the floor to you.
Hello, all. This is Kevin Conrad. I'm in New Orleans, Louisiana. I'm medical director of community affairs and health policy here, as well as a practicing hospitalist. I won't talk too much about operations, but if you have any questions at the end, feel free to chime in. And much of what we've done is similar to what the experience is in Chicago. From the get-go, I think that we are at our peak, we were about up to 200 inpatients. We peaked about April 5th, and so we're certainly on the downswing of things, approaching about half the capacity we had at our peak. So that's all good. From the start, this reminded me of, and reminded everyone else who'd been there, of Hurricane Katrina. And so we had sort of a similar feel to that. When this hit, we knew, gee, this is going to be bad. And we kind of knew what steps to take somewhat. But I think the main thing we knew is that, wow, this can turn bad, and it certainly did. From the get-go, we had daily huddles, and in the beginning, we made a point to, in each huddle, to talk about anything positive. Gee, we had less admissions last night than before, or something along those lines. At the end of each COVID huddle we did at 7 o'clock in the morning, we brought up something specific that was positive. In the beginning, there really wasn't anything positive to talk about, so we talked about records. Gee, we admitted more patients than we've ever admitted to, last night. Gee, our census is as high as it's ever been. So we took a little bit of solace in that. I think we also did a pretty good job of injecting a little bit of humor to the situation, knowing that this was going to be a marathon and not a sprint. So we didn't keep things entirely too serious at the huddles. We also brought up the fact that this institution has been there before, we'll probably get there again, and we'll get through it. And so that was sort of comforting in that, gee, to the people who hadn't been there, that there was a template, there was a leadership structure that had dealt with this before. We have decompression rounds that we started 2 weeks ago. It was mentioned that, for the first couple of weeks, we were functioning on adrenaline. And so we didn't really, have the need to decompress. But as we got to sort of week 4, week 5 of this, that's when we started to see some fatigue. So twice a week in the afternoons, we're doing some decompression sessions with some counseling, etc. We've also heavily upstaffed our services with people from other areas, such as our HEMONC fellows, our cardiology fellows, etc. So basically, our services have a load now that are about half as much as the pre-COVID era. We've relied heavily on telehealth. That's been a huge component. And I would add that my experience has been that telehealth is providing, I'm just looking at the data now, telehealth is providing excellent care, and certainly in some circumstances, better care, because that we have time to sit down, talk to the patients, review their chart in real time. And for the most part, the patients are extremely appreciative of the care we're providing, and that's been reassuring to us. We've been into this a month, so our patients' fears have changed from a lot of apprehension to somewhat being resigned to this, and patients and families certainly dealing with this a lot better than we saw in the beginning. We have made drastic changes to our hospital structure. We've physically walled off areas and wings, and we're certainly at the area now as we're thinking about, okay, how do we open up the hospital? And certainly next week, we're going to begin doing elective procedures, and we're making plans for that. I do not think it's too early to think about the hospitalist role after this and the importance that we've played in this and how we, our status and our remuneration might be considered differently in the future. I bring that up to the group to maybe put that bug in your ear as well. And that's about all I have. and I'll open up to the floor for questions, as I think I'm the last speaker.
Great, thank you, Dr. Conrad, and thank you all the panelists for sharing what you're doing in your sites. It's been really interesting, I think, to hear how much communication has changed and how important transparency and the frequency of communication has changed just in this time, and how much that's you know, even though care has shifted, the amount of FaceTime that folks are having with their peers, that seems to be a common thread. That, you know, as much as, you know, we all can't be together physically all the time, you know, we're still finding interesting new different ways to spend more time together. So I want to remind folks that you can raise your hand, and we will try to open up the floor to folks if they want to share strategies that their groups are using. And in particular, you know, we'd love to hear about how communication and leadership strategies have changed, because that really, I think, has come through pretty clear, that leaders are really stepping up and they're changing the way groups are communicating with one another to try to begin to support each other in new and different ways that were completely unexpected 7 weeks ago.
Yeah, Joshua, you are very right about communication. I can, you know, there's one incident happened on one occasion, not as an incident, but during one of our meetings, one of our hospitalists, he said, look, she said, look, I know that this is the first time anyone is going through this type of pandemic. New Orleans, of course, have Kevin had experience with Katrina, but this type of stuff. And so she said that I know that no one has answers. We just want to know how we can help and what's going on. And so I think that at least to me, told a little bit about communication, that is really important key here. That our hospitals and providers are smart enough to know that many decisions that we make may not be the right or best at that very moment, but they realize that once they're with us in making that decision and helping us.
That's great. I'm curious for any of the panelists or any of the participants, you know, as it feels like a lot of sites are transitioning from the initial shock to the system that we're in a pandemic and that adrenaline has sort of worn off. And I think the reality that so much of hospital medicine and truly of our daily lives has been changed probably for a fairly significant amount of time. I'm curious, you know, particularly, have there been discussions about, you know, Sarah, you mentioned that you went from a monthly hour-and-a-half call to now weekly hour-plus calls. Has there been talk about, are those strategies going to continue as, you know, the marathon of the pandemic continues? And if not, are there plans to sort of adjust?
Yeah, I guess I don't know if Nebraska is maybe Nebraska Medicine's the oddball in terms of this discussion and our panelists. We didn't flatten the curve too well, but it's so flat that it is like a for sure marathon for us. Like it's been the hyped up energy and preparedness and all of this and the communication and everything. It just feels like it's, and we're still not at our peak, or we can't even like see the peak yet. Or when it's going to come, and we think it's early May, but who knows? And so for us, I think we kind of, yeah, we had this initial surge of all hands on deck and all this communication. Now everything's kind of stood up, and now it's just kind of on autopilot. And so I don't even, that's part of the uncertainty of it all. I don't even know what normal will look like or when it will happen. I don't think anybody does. I think everybody really loves the seeing one another's face. And like, I think people really love connecting and talking, and even, you know, just the frequency at which the meetings are occurring may be something that sticks in one way or another. I don't think we're gonna have phone calls anymore. I think we're gonna have Zoom meetings so we can see each other's faces. I think in order to meet more frequently, when we all can't be in person, we're gonna just do it, because now we're all like Zoom experts. So I guess I don't know the answer to your question. I think that's, I'm saying that all the time because nobody knows the answers to a lot of these questions, and I think it's helpful when leaders just admit that. Like, I just don't know, but we're doing our best and we'll see. But I think that there's some energy around the communication and transparency. It just feels good and it feels right.
I do want to remind folks that you can raise your hand to join the call. Oh, and actually, Luke, if you want to unmute Therese Franco, she'd like to share a little bit about the Pacific Northwest SHM chapter webinars that have been happening.
Yes, Therese, you're live, so welcome.
Okay.
Thank you so much for joining our conversation.
Sure, thanks for having me. I just thought I would share a little bit about our chapter's activity, and actually some of the other professional societies in the area. So my name is Therese Franco, and I'm president of the Pacific Northwest chapter. In my work, I am half-time clinical hospitalist and otherwise associate regional medical director for the CHI Franciscan system. And we've got 6 hospitals, 2 in King County with Seattle, so lots of COVID activity there, 3 in Pierce County, which is number 3 for COVID activity in the state of Washington, and then 1 in Kitsap County, which hasn't had a lot of activity. And on March 12th, which is the day that our governor actually shut schools down, we were scheduled to have a physician wellness event with Kinsley Coble. I think she may be on the line. But there was so much going on with COVID that we just kind of turned it into a listening session about COVID. And from there, it became apparent that the group really wanted, you know, more sessions. I think 1 to connect, but also 2 just for technical information. I think hospitals have really been craving that. How do I diagnose? How do I treat? What's the current algorithm? How am I supposed to do my PPE? Where do I get PPE? What is the CDC saying? All of these things are like moving targets for the first couple weeks. And I think that frequent communication from the various organizations was happening, you know, like the Swedish Medical Center, Evergreen Medical Center, everybody having kind of weekly or even several times a week town hall meetings, but those were very operational in nature and not as sort of social and technical. So that's sort of what our webinars were about. And I just invited people from different hospitals, and they shared their experiences sort of around the Puget Sound. So we had, I think, 7 speakers from 7 different organizations, and we did 3 weekly webinars. The first one, we had more than 200 attendees, and then it's sort of plateaued at about 80, somewhere between 80 and 100. And so with that plateau, I've decided to spread out our chapter webinars, and that kind of we're at a point where we're contemplating opening elective surgery. And on the one hand, I think people are really excited about that. On the other hand, I do think it's stirring up a little bit of the anxiety. So I can see where we might spread the webinars out for now, but as things start to ramp up again, I wonder if people will want to go back to weekly. So we covered a lot of different topics in the webinar. Briefly, I heard people touch on telemedicine. CHI we did a lot with flexible staffing and telemedicine, and that was a real positive experience. We were offloading between 50 and 60 COVID patients from the 6 hospitals a day. And then when our census really started to come down and the burden of COVID in our system really started to decrease, then we moved away from telemedicine, and that was a really difficult transition for people. That was last week. So it exacerbated anxiety about personal exposures. The other thing that was hard was that we were using a couple providers that had, conditions as identified by the CDC, so sort of immunocompromised, advanced age, pregnancy. Some of those providers took unpaid leaves of absence because they were practicing with telemedicine, but they don't feel safe practicing in the hospital right now. So that was also a hard transition. So the telemedicine was super successful, and it was a big help to the team. And sort of letting go of that has been the most recent challenge. But it's been eye-opening to sort of look across the system at our volumes and how we can level load. And I do think there are lessons that we will take forward on this from our staffing. The other thing I would say that we touched on in our webinars was about communication. And on the one hand, I think there's a want for frequent communication. On the other hand, we did find that it was creating, it was sort of exacerbating the sense of overwhelm that people talk about. So I think frequent, brief communication with clear ability to escalate appropriately is the best model. And I actually like, out of Intermountain Health, they have something called a tiered escalation huddle. And I think that that's a really excellent model. I think it's been written up in like the Harvard Business Review and any JM Catalyst. But I think that's a great model. I think, just setting clear boundaries and clear expectations, and then a clear plan for when things aren't going well, how do we resolve that so that the meetings are actionable. We covered a lot of other things in the webinars, but I think that's been nice for people. And then the other thing is we really, I would say our chapter really bonded with different professional organizations in the area. So we worked with the Washington State Medical Association, had webinars that they scheduled around our webinars. So they had critical care webinars on Tuesday, and we had hospitalists on Wednesday, and many people attended both of those. We connected with the Washington chapter of the ACP, and out of that, we're going to do a joint CME course together. We connected with the King County Medical Society, and they have really done some phenomenal work as far as rallying the community around providers. They have gotten donations of lodging, of PPE, different things. And so I've really enjoyed seeing these different organizations come together and rally around the cause. And I think we've been, I feel very positive about the experience for what it is. I actually see people coming together. I see a lot of innovation that I think is going to stick with us. I think life is going to look different after this, and I think it's going to look better. And I think getting that message out there, because I genuinely feel it, I think that has been maybe helpful to people. I think promoting positivity and promoting positive thinking has been helpful, although I will say you have to be careful about that, because if you don't want to minimize somebody's distress, right? So if they're having a really tough time, it's more important to be quiet than to talk. And with that, I'll end.
Thanks, Therese. We had a direct question for Sarah, but I know a few of the panelists mentioned the sort of decompression meetings or the sort of open meetings that included things like deep breathing exercises. Are those through a website or an app, or like how are you structuring and then the website for paying it forward when you're calling out the superstars or the folks who need a pat on the back? You know, how are you structuring that? How is that like operationalized so folks might be able to replicate some of that?
Yeah, well, anybody who's interested, if they just want to email me, I can give them full detail, but quick overview, I guess. The sessions, we really want to feel like intimate, and we want to have it feel like it's collegial and it's the faces and the people that you know. And so like the deep breathing and progressive muscle relaxation are our own psychologists and psychiatrists that are on campus. And we give people the option to turn off their video camera, but we encourage them to keep it on. And I stay on and I actually, you know, do my breathing and we walk them through it. And we say this might feel awkward and it might feel funny, but I mean, I've yet to have somebody say that wasn't just such a therapeutic, nice, wonderful thing to kind of go through. It just kind of happens. We definitely have links to tons of resources and websites, but I just find that like people don't, right now at least, people aren't taking like that extra step to click on a link and scroll down a website and then open a video or download an app. Like you almost just have to kind of do it for them so that they can feel how good it feels. And so that was kind of the model that we adapted there. And then the pay it forward, we just had our marketing team put together a form stack. And so it's a link that requires no additional login or sign in. Like anybody on this call could actually use our appreciation form right now. And it comes to me and my one other person, and we just divvy them up. And then we have a slick way to download all the responses and then put them into an email template. So then they just go via Outlook email. And we have people identify who the supervisor is for us so that it just makes it easy. And then in the email at the bottom of the form is just that link to that same URL. So it's simple and it feels homegrown and it feels organic. And I think that's what's been successful. We kicked it off April 9th and we've already had 400 notes shared through that. So that's been really fun to see those come in, but happy to give more detail if needed.
Excellent, thank you, Sarah. We do have 2 hands raised. So first we'll go to James Clements. James, hello, you are unmuted.
Hello, my name is James. I'm in Portland, Oregon at Oregon Health Science University. I have to quickly shout out to Dr. Richards. I'm a graduate of Nebraska medicine back in 2006, and know Chad Vokoun from some leadership meetings. And Rachel, Cyrus, I think you were a senior resident of mine when I was an intern at Utah. It's nice to
right, I recognize the name too. Yes.
So I'm a director of well-being for hospital medicine, and Dr. Qayyum, our institution has done a lot like yours, a very great response with an emergency operations center, fairly highly coordinated. But in our own division, the things that we've done really are around the leadership, and it's highlighted the importance of staffing and workload and the tangible things for well-being. I rolled out some things, and we have institutional support for counseling and mindfulness and a lot of other individual things, but people wanted to know what's the plan. So we worked together, created the surge staffing plan to give people a sense of security that there would be a plan B, C, D, E, F, and all of those things. And then in our own leadership structure, we started meeting daily, like Dr. Richards was talking about. Normally, we're a very egalitarian group. There's work groups and work committees that last 6 months to make one decision. And we just started really, funneling a very kind of hierarchical leadership chain of command so we could make decisions quickly to change. And then started having daily huddles with the hospitalist team Monday through Friday, 20-minute check-ins, really with the goal of escalation, as was mentioned by the prior caller, on how do barriers get escalated? Like when, all the different service lines were all changing their, policies about if they're going to see patients with COVID or not. And that's very frustrating as a hospitalist. Like, I can't get the cardiologist, neurologist, surgeon, whoever to see the patient. How do you escalate those barriers? And so we had a clear chain of escalation. Our division head is on our emergencies command team for the institution, and so we're able to escalate those things, and people get their questions answered in a timely manner. So it's really those practical things that I think were the biggest well-being boosts on our team.
Excellent. Thank you so much, James. Well, folks, that brings us to the end of our time. I just want to thank everyone, especially our panelists, for joining us today and carving out time in your very busy schedules to participate in our first ever well-being discussion. Again, if you didn't have a chance to share or have more that you would like to contribute to the discussion, we just invite you again to reach out to the rest of your colleagues on HMX, or to email SHM directly at ideas@hospitalmedicine.org. So from all of us here at the Society of Hospital Medicine, we really appreciate the service and sacrifice you are all making during this pandemic. I don't think we've ever been more proud to support and serve you all. And so with that, we wish you the best to you and your families, and thank you, everyone.